Good morning, everyone. Welcome to Telehealth at the Crossroads. I am Dr. Ariel Santos, Principal Investigator for the Texas-Louisiana Telehealth Resource Center. As many of you know, we have had a live conference annually for a number of years, but these are unique and challenging times, requiring social distancing. That's why this webinar series was developed. The public health emergency and associated waivers has driven an upsurge in telemedicine and telehealth. This is an exciting times to be in telemedicine. We are working to keep you up to date on changes and provide you resources to advance telehealth in your organization and practices. This will be the first of the series of summer webinars provided for you all. Before we started, a bit about Telehealth Resource Center or TRC. TEXLA TRC is federally funded by the Health Resources and Services Administration, or HRSA, to provide technical assistance, outreach, and education to advance telehealth. We serve all of Texas and Louisiana. The Louisiana Office of Rural Health, under the name Well Ahead Louisiana, serve as a support representative for Louisiana. We are one of the 12 regional and 2 national centers covering every state and territories in the Pacific Basin. We formed the National Consortium of TRCs to draw on all of our expertise and create efficiencies as it relates to telehealth. We welcome our speakers and attendees today. I would like to personally thank every one of you who participated in this educational program, and would like to thank Texas Tech Health Sciences Center, F. Murray Hall Institute for Rural and Community Health, especially Cameron Onks, Kelly Munoz, and Becky Bounds. I will now turn it over to our very own Cameron Onks, Attorney and Director of Innovation in Health Technology, to introduce our distinguished speakers.
Thank you, Dr. Santos, and thank you to everyone for joining us. As Dr. Santos mentioned, my name is Cameron Onks. I'm Director for Innovations in Health Technology here at the TTU-HSC F. Murray Hall Institute for Rural and Community Health. I'm originally an attorney by training and have worked extensively in telehealth policy and compliance, which is why I have the distinct pleasure of introducing today's speakers to you. Monica Shimileski is a partner and healthcare life sciences lawyer with Foley & Lardner, LLP. She focuses her practice solely in representing healthcare providers, pharmaceutical and medical industry companies, or medical device companies rather, and pharmacies in the area of healthcare, healthcare transactions, clinical research, supply chain, and food and drug law. Monica is co-chair of the firm's life sciences industry team, and she's also vice chair of the firm's healthcare industry team. Monica advises a number of clients, including hospitals, health system and physician groups, on regulatory and compliance issues presented by telemedicine and telehealth. Her counsel includes, but is not limited to, structuring and negotiating professional services agreements for telemedicine services and composing telemedicine policies and procedures. Also joining us today is Kyle Fichet. Kyle Fichet is a business lawyer and of counsel with Foley & Lardner. She's a member of the firm's government and public policy practice, as well as healthcare and life sciences industry teams. Her practice focuses on advising clients on regulatory and compliance matters involving Food, Drug, and Cosmetic Act, the False Claims Act, the Anti-Kickback Statute, the AdvaMed Code, and the Pharma Code. She also regularly drafts and negotiates agreements required for the development and commercialization of pharmaceutical and medical device products. And prior to joining the firm, Kyle held an in-house position at pre-commercial and commercial stage companies. With regard to telemedicine, Kyle advises suppliers, physician practices, consultants and vendors, and a variety of other healthcare entities on a range of business, legal, and regulatory issues affecting the telemedicine industry. She handles matters involving contracting, fraud and abuse compliance, Medicare and Medicaid reimbursement, self-disclosures and overpayments, the anti-kickback statute, physician referrals, healthcare marketing rules, HIPAA, corporate compliance programs, contracting, confidentiality and information sharing, and policies and procedures. So without any further ado, I'd like you all to join me in welcoming today's speakers as we discuss the future of telemedicine and COVID-19's impact on telemedicine.
Great, thank you, and good afternoon, everybody. This is Monica Shimoleski, and we are pleased to be with you this afternoon to be able to speak to telemedicine, at the crossroads. What is the future of telemedicine, and significantly, the impact that COVID-19 and the public health emergency have had on the use of telemedicine. So bear with me 1 minute. Here we go. I just want to screen here. So what we're going to talk about today is, like I mentioned, the impact on telemedicine, what changes we're seeing, what changes CMS, Medicare have implemented, changes relating to HIPAA and privacy, controlled substance prescribing, licensure waivers, changes in relation to parity orders, and then try to look a bit into the crystal ball and determine, what's next? What does the future for the use and expansion of telemedicine hold? And I'll say at the outset, telemedicine in the past has wonderful possibilities and wonderful capabilities. Unfortunately, there's always been some perceived obstacles to the use and the deployment of telemedicine. And fully in the past, we've conducted nationwide surveys of hospitals, health systems, providers, CEOs to try and gain an understanding of what do they perceive to be the obstacles in their use and embracing of telemedicine. And always at the forefront were two main issues, two main obstacles, those being a perceived lack of or not enough reimbursement, not enough coverage for the provision of services via telemedicine. And then the second was a lack of it being embraced by the providers or by the health systems. It was perceived that the use of telemedicine really has not been a priority for hospitals or health systems or providers. It's something they thought would be useful, but had never been a priority to implement into their normal operations. Well, all of that has changed with COVID and with the the issuance of the public health emergencies. Bear with me as I'm trying to. Here we go. So, sorry, I'm just having trouble advancing the slide. Here we go. Thank you. So one, if there are silver linings to COVID and to the public health emergency, I think that one of them is it has put telemedicine into the spotlight. Providers, executives of health systems and hospitals are now looking at and embracing and utilizing telemedicine like never before. And it has prompted the government at a federal level and also at a state level to examine the regulation of telemedicine and the use of it and allow for its expanded access. And all of this really, it was possible due to due to the public health emergency. And I'm sorry, I'm trying these slides are not cooperating with me. So essentially, so what happened? What took us, what brought us to this spot, which I'm sure everybody is well aware of. In January of this past year, the U.S. Department of Health and Human Services, the DHHS or the DHHS, the Secretary of the HHS declared a public health emergency. With that declaration, the President, in March of 2020, issued a proclamation that the COVID-19 outbreak in the United States constitutes a national emergency. So what does that mean? What does that do to allow for the expanded use of telemedicine? When those emergencies were declared, and now again I'm trying to advance the slides here. Forgive me, I'm trying to advance the slides. It is not quite. So here we go. I apologize. I'm not quite sure why the slides aren't advancing for me right now. Okay, so here let's try and get back on track. So essentially, what this means is when there is a major disaster, implemented under the Stafford Act, it allows the president to implement, exceptions to the regulations, and included in those are what we're calling the 1135 waivers under the Social Security Act. Pursuant to that, the Secretary of the HHS may waive or modify certain regulations under Medicare, Medicaid, HIPAA, etc., as necessary to ensure that in an emergency situation, like such as in the COVID pandemic, that there are sufficient healthcare items and services available to meet the needs of individuals enrolled in these programs. So the purpose is to ensure that individuals, covered by Medicare, Medicaid, et cetera, are able to have access to necessary services, under the Act. So thank you. Becky, if you don't mind advancing to the next slide, that'd be great. So in relation to these 1135 waivers, Congress passed and the President signed 3 bills and enacted them that provide for varying degrees of regulatory and financial relief for healthcare providers during the COVID public health emergency. Now, the result of that is these bills have triggered a cascade of actions from CMS, which are designed to increase flexibilities for providers and to increase access to and use of telehealth services. And so why is this important? So at a high level, it's important to remember that telehealth is largely regulated at the state level. Each state has their own laws and regulations that address, and some states have limited laws and regulations that address the provision of care and service via telemedicine. These laws will address standards of practice, licensure, what modalities, what types of technology need to be used when you provide services via telemedicine. There's, the states will have laws addressing patient consent, the physician-patient relationship. There are laws addressing controlled substance prescribing and general, prescriptions. And we'll be talking about those as they go on. At the federal level, CMS has control and influence over the provision of care via telemedicine via its ability to control what it's going to reimburse and how they will pay for these services. So with these 1135 waivers, CMS has been able to, shall we say, relax their standards for their provision of reimbursement for telemedicine services. At a high level, pre-COVID, there are certain requirements that you would have to meet in order to receive reimbursement from CMS for care provided via telemedicine services. Those requirements included that the patient had to be in a qualifying rural area, either in a health professional shortage area or outside of a metropolitan statistical area. The patient has to be at a qualifying facility or site, which is also called the originating site. And those included, hospitals, skilled nursing facilities, for example, community mental health centers, critical access hospitals, and the like. While there were some, exceptions to that, such as, for, ESRD services, but overall, the originating site requirement, was perceived to be very limiting because the patient, would have to go to the hospital, would have to go to a critical access hospital, or be in a skilled nursing facility. So essentially, be in a facility where they're already able to receive medical care. Another requirement was that the service had to be provided by an eligible practitioner, which would include physicians, nurses, physicians' assistants, etc. The technology used to provide the service has to be real-time audio video. You need to have the ability to interact with the patients. And then the service has to be covered by a list of, and including a list of CPT codes, that Medicare covers. So that was the pre-COVID high-level basis. So Medicare, in relation to the 1135 waivers, has now changed this. And we're going to walk through and discuss some of these changes and what they mean and how they have allowed for the expansion and use of telemedicine. So actually, if you could back up, Becky, with the slides. There you go, perfect. So as mentioned, pre-COVID, there was a limited number of qualifying, oh, actually go back one more. I think, did we have one more slide? Okay, no, I'm sorry, you were right, go forward one more. So essentially, Medicare had a limited number of sites where the patient could be in order to qualify for reimbursement of services that are performed during with telemedicine. Medicare has expanded this so that now during the public health emergency, telemedicine services may be provided to patients located in their homes. This in itself is a huge win because it allows for the patients to not have to travel to a hospital or to one of these qualifying sites. The government acknowledge and recognize that in the state of emergency where social distancing is the norm and it's required and it's needed to help try and curb the spread of the pandemic, there is a desire for patients to remain in their homes and to still be able to receive this medical care. Patients, want to, receive the care and not be exposed to potential COVID in hospitals and emergency rooms and physician offices. So with this change by CMS, allowing the patient to be in their home and their home qualifying as an originating site allows for greater access to the use of telemedicine for patient care. So that was the first big change that CMS made. Next slide, please. So the next change has to do with the provider types. So Medicare, again, pre-COVID limited the types of providers that were eligible for reimbursement when providing telehealth services. Now those included, again, what we think of as traditional providers such as physician, nurse practitioners, physician assistants, etc. However, CMS has now greatly expanded this definition. So the types of healthcare providers that can furnish telehealth services and receive reimbursement now include all providers that are actually eligible to bill Medicare for their professional services. So this expanded the definition to now include, for example, physical therapists, occupational therapists, clinical psychologists, and licensed clinical social workers. So now, as opposed to limiting the providers that can provide services, we're expanding the access to patients by allowing them to be in their homes, and it's allowing the patients to receive these services by any provider that's actually eligible to bill Medicare for their services. So that is an incredibly large expansion. Next slide. So licensure. So again, licensure is regulated by the states, but Medicare also required that, consistent with the vast majority of state laws and regulations, Medicare required that the provider be licensed in the state in which the patient is present. So if you have a patient that is located in Wisconsin, they're in their home in Wisconsin or they're in a hospital in Wisconsin, and the provider is located in Illinois, the provider that will provide the services to the patient, that provider needs to be licensed in Wisconsin to provide the services to the patient. Now, I'm sure everybody's aware that there are state licensure compacts, which allow providers who are in states that participate in the compact. It's an expedited means for the provider to be licensed in multiple states. And so essentially, under the compact, the provider undergoes really they reconduct a limited background check, make sure their credentials are up to date, and it's his or her home state that does this. And once that's done, the provider then is able to essentially choose any of the states that participate in the compact to become licensed in. However, now in relation to COVID and the public health emergency, Medicare has expanded upon this. And they've said that CMS has stated that they will waive the requirements that physicians and non-physician practitioners be licensed in the state where they're providing services, meaning they don't have to be licensed in the state where the patient is physically located if 4 conditions are met. And the conditions are really reasonable, at least in my opinion, that the providers should be able to meet them. The conditions include that the provider has to be enrolled in the Medicare program. He or she must possess a valid license to practice in the state that relates to the Medicare enrollment. So they need to have a valid license in his or her home state. So again, if the provider is in Illinois, they need to have an active license in Illinois. When the provider furnishes the services, whether it's in person or via telehealth, in a state in which the public health emergency is occurring, they're providing those services in order to contribute to the relief efforts in his or her professional capacity. So for example, states where they border one another, we've been seeing a lot of practitioners licensed in one state, stepping in to assist to provide relief and additional professional care to patients residing in their cross-border states or local states to help supplement and provide care that's lacking in relation to the public health emergency, where a number of resources are being devoted and directed to the treatment of COVID patients. Providers are stepping up to ensure that additional and regular care can be provided to patients on an ongoing basis. Patients who have chronic care conditions that need these services. And then finally, the last condition is that the provider cannot have been and cannot be excluded from practice in his or her home state or in any other state which is part of the pandemic. So in this case, the pandemic is nationwide, so the providers cannot be excluded from practice in another state. Of course, these are the waivers that CMS has put in place, but these do not mean that the individual state laws addressing licensure don't need to be followed. So it's important to remember as we're looking at the CMS exceptions and the expansion of the use of telemedicine, these still need to be conscious of and make sure that you're compliant with the applicable state requirements as well. Now, many states have, in relation to COVID and the pandemic, also enacted similar exceptions and waivers, but I don't want people to forget that you have to be compliant with the state licensure requirements as well. Next slide, please. So then covered services, as mentioned, Medicare pre-COVID had a list of a limited number of services under the physician fee schedule for which payments would be made for telemedicine services. I will say that even pre-COVID, Medicare was working to expand their coverage. They had issued new coverage for certain virtual care services, for example, virtual check-ins and for e-visits. But in light of the pandemic, in light of COVID, CMS has temporarily expanded the list of telehealth codes that are eligible for reimbursement. For example, there's coverage for initial and continuing intensive care visits, coverage for care planning for patients with cognitive impairment, group psychotherapy, The most common, CPT codes for which coverage is available for telehealth now include, office or outpatient visits, consults, telehealth consults, and follow-up inpatient consults as well. So there is a long list, and you can actually, CMS on its website has an entire listing of all the various CPT codes for which coverage is now available for when the service is provided during service provided via telehealth, both during and then pre-COVID. We're going to be watching, and it'll be interesting to see, and the general consensus is there will, post-COVID, when we ever get to a post-COVID situation, which I know everybody hopes is soon, that due to the widespread embrace, and so far was perceived to be a very successful embracing implementation of services via telemedicine, there is the hope that the expansion and the increased CPT codes will remain and be able to be used. So next slide, please. And so then in terms of the patient relationship, I am actually going to step back and ask Kyle, my colleague Kyle, to start talking a little bit about the patient relationship and then go into some privacy considerations and controlled substances. So Kyle, if you're ready to take it away, I'm going to pass the baton.
Awesome. Thank you so much, Monica. Hi, everybody. Thank you for having me. As Monica suggested, I'm going to talk for a minute about patient relationship. So under the relationship required created in the Coronavirus Preparedness and Response Supplemental Appropriations Act, that is a mouthful, the patient must have seen the doctor or somebody in a practice before a telehealth visit can be had and reimbursed. And that's not completely unusual, particularly under Medicare, that you have to have this prior relationship established. But CMS announced that it's not going to enforce the relationship requirement during the emergency period, which is really important, right? Because if you're looking to receive services, and let's say you either don't already have a primary care physician or you need some specialty type of care, it's really important that at least during this time when nobody wants to go to a physician's office, that you are able to do so without having to go in. So this allowed for people to appropriately socially distance and protect providers as well. So that's what's happening during the emergency period. And then the CARES Act subsequently codified that policy by revising the changes made in the Coronavirus Preparedness and Response Supplemental Appropriations Act. So again, the take home here is basically that you don't need to have a prior established relationship based on an in-person visit with a healthcare professional before receiving services. Next slide. Thank you. So this one, in my mind's eye, is almost as important, if not more important, than where you can receive services. So, oftentimes when I think about the barriers to telehealth, I think that Monica covered earlier, the requirement that a patient be in a rural tract census area and or in a health provider shortage area, and that they could only receive services in specified locations was a big barrier to receiving telemedicine. Because if you have to get up and leave your house, that's a pretty big barrier on the patient side. But on the provider side, parity was a big issue. And I think that we skipped slides one forward too many here. So back one. Thank you so much. So payment parity, in my mind's eye, like I say, is huge from the healthcare provider side of things. So it used to be the case that for services that had different rates for in non-facility and facility services, Medicare would use the lower payment rate when services were furnished via telehealth. So That's a very technical way of saying that in-office visits and telehealth visits were not paid for at the same exact rate necessarily under Medicare. The telehealth payment to the furnishing practitioner now, post, in this sort of post-COVID world or during the COVID world, is the same for in-person services. So CMS ultimately will assign the payment rate that ordinarily would have been paid under the physician fee schedule as if the services were furnished in person. So that's extraordinary, right? When you think about providing services from a healthcare professional's perspective, a healthcare professional isn't going to want to engage in telemedicine if he or she is either not going to get paid, which can be the case, or get paid at a much lower rate. And that it's an equity issue, really, more than anything else. So that's a sea shift, and particularly for healthcare providers. And we'll talk about whether or not that'll stay in place in a little bit. Next slide, please. So required co-payments, this is a very, like a sine qua non, I suppose, of Medicare, is that the patient has to shoulder some responsibility for the fees associated with care. So in the pre-COVID-19 universe, co-payments were generally applicable for telehealth services. So much like an in-office visit, Medicare patients would have a copay. However, HHS announced flexibility for healthcare providers to reduce or waive the cost sharing requirements for telehealth visits paid by federal healthcare programs. And that's typically a huge compliance no-no. That, in fact, Monica, I think, advised clients all the time that want to, as a matter of, trying to be charitable and provide care as expansively as possible, do something to reduce some of the cost burden for patients. And unfortunately, under Medicare, it is a core compliance principle that patients have to shoulder the burden for the cost of healthcare services. So this is a big deal too. And again, it just gets to this recurring theme that providing healthcare services has been made far easier, and particularly in the telehealth context amidst COVID. Next slide, please. So now there's also a frequency issue. So in advance of COVID, the frequency of telehealth services was limited for certain Medicare services. So you could only receive or provide certain number of services to any given patient a certain limited number of times. And again, as you can see, there's like this recurring theme. There's this limitation about where you are. There's a limitation on how much money can be paid. There's a limitation about how often you can receive services. And there's been a shift that now certain services no longer have limitations on the number of times they can be provided by Medicare telehealth. So for example, a subsequent inpatient visit can be furnished via Medicare telehealth with no frequency limits. A subsequent skilled nursing facility visit can be furnished via Medicare telehealth with no frequency limits. A critical care consult code may be furnished to a Medicare beneficiary by telehealth beyond the once per day limitation. So there are just a couple of examples, but they demonstrate some places where limitations had previously been in place. Next slide. Modalities. So modalities in telemedicine, telehealth generally refers to how it is that you can reach and communicate with a patient or a provider. So in advance of COVID-19, I think Monica mentioned this, Medicare required the use of interactive audio video telecommunication systems. So really it was like real-time audio visual components had to be used. The use of telephones only were excluded from coverage. Amidst the coronavirus, providers are allowed to use the audio-visual functionality on mobile phones. We'll talk a little bit more about that in a second. But that's a big shift. You couldn't just use FaceTime, for example, in advance of COVID to conduct a telehealth visit. So now CMS will allow reimbursement for certain audio-only E&M telephone codes to new and established Medicare patients. And also opioid treatment programs may also conduct therapy and counseling sessions through audio-only telephone calls. So this is a particularly important change, and admittedly early on in the crisis, I sat in on a number of calls with CMS, and this was a recurring theme for conversations with CMS about what changes were going to be really, really important changes during the time of COVID. And being able to use telephone was a big one because the aging population doesn't always have smartphones. And so that, again, was something that kept getting brought up on these calls with CMS is, look, you know, we'd love to engage in telemedicine. That's fantastic, but a good chunk of our population that really needs us right now, they don't have smartphones. They can only do this via the telephone, or even if they have a smartphone, they have absolutely no idea how to utilize this particular function. So, you know, the loosening of some of the modality requirements aren't particularly helpful if you don't include the use of telephone. So this was big. Next slide. So what made it possible for things, you know, apps like FaceTime to be used on a telephone is that the HHS Office for Civil Rights announced that it would exercise enforcement discretion, allowing the good faith use of popular video chat applications like FaceTime, Zoom, Skype. And this was important because in advance of COVID, anybody looking to practice telemedicine had to do so utilizing a HIPAA-compliant telemedicine platform. So there are a number of companies out in the universe that provide this HIPAA-compliant platform for use, I believe Zoom being among them. And they charge an annual or a monthly fee, or have different pricing schemes. And what they offer is this beautiful HIPAA-compliant platform. The hard part is amidst COVID, when all of a sudden everybody's scrambling to use telemedicine, you know, there's, again, this barrier to entry. Number one, like every provider looking to use telemedicine would all of a sudden have to identify a HIPAA-compliant platform provider, sign up, get all of their patients moved to using this particular platform, whatever they signed up to use. And, you know, in the general state of things, that's perfectly fine. And in fact, I think there's a very clear expectation of privacy in the context of healthcare, of course. But during a public health emergency, the idea is to get care to people as quickly and efficiently as possible. So the Office of Civil Rights said, and I was almost shocked by this because privacy is so incredibly important, but it makes sense that being able to use popular applications like FaceTime and Zoom and Skype and so forth was really the only way to see this ubiquitous shift to use of telemedicine. Next slide, please. Thank you. So another really big shift for telemedicine was controlled substance prescribing. A prescription for a controlled substance issued via telemedicine required an in-person exam before telemedicine could be used. And, you know, telemedicine providers often said, listen, this is really akin to a barrier to telemedicine. So if you have to, particularly for telemedicine only operations, it becomes virtually impossible to provide care if you have to have this in-person exam before you're able to use telemedicine. So the US DEA registered practitioners now may issue prescriptions for Schedule 2 through 5 controlled substances without meeting this required in-office visit, provided that the prescription is issued for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. The telemedicine communication is conducted using an audio-visual real-time two-way interactive communication system. So here you see the sort of gold standard real-time audio-visual two-way interactive communication system rearing its head again, and that the practitioner is acting in accordance with applicable federal and state laws. So that piece is a critical piece. Even though federally, the DEA has relaxed this requirement for an in-person exam in advance of prescribing controlled substances via telemedicine. There are state laws, and a number of states have laws limiting the use of telemedicine for prescribing controlled substances. So before any providers go out and start using telemedicine for prescribing with patients that they have not had an in-person exam with yet, it's very important to check your state laws as they relate to controlled substance prescribing using telemedicine. Next slide, please. So state licensure waivers, as Monica suggested before, Medicare waived licensure requirements, and for Medicare, that's one system, but states also have, and probably people are most familiar with the state licensure requirements. So, when you are providing services across state lines, if I'm in Massachusetts and I have a patient in Illinois, I have to be licensed in Illinois to provide services to that patient. That's the pre-COVID model, and there is the Interstate Medical Licensure Compact and a similar one for physical therapy and for nursing, but not every state actually participates in that compact. So that compact essentially allows physicians that practice in states that are a member of this particular compact to practice in other member states. But there are, I believe, currently 29 states that are members of the Interstate Medical Licensure Compact, and it's still a process. There's still a process involved with, if you're a provider, getting enrolled and so on and so forth. So what happened in COVID, and I think we saw this very early on with New York, that there was just this huge shortage of providers that could care for sick patients. So we started seeing across the United States relaxed licensure requirements related to not only physicians licensed in another state treating residents within a given state, but we saw that with respect to nursing as well. So there was just, particularly in the hotspot areas, there was this incredible demand for providers, and asking providers to engage in the traditional, it can take well over a year to get licensed in another state. So asking providers to go through that process wouldn't make a whole lot of sense. So what happened, and I just use one example, Pennsylvania, Governor Wolf granted the Department of State's request for a suspension to allow licensed healthcare providers in other states to provide services to Pennsylvanians via the use of telemedicine without obtaining a Pennsylvania license for the duration of the emergency. Many states across the United States have some kind of state licensure waiver in place, which has been really nice for some of our clients that are trying to practice telemedicine for the first time. You can do so right now under this state licensure waiver exception, but it is really important to note that different states have varying degrees of this licensure exception. So some states have just said, okay, as long as you have a valid license in your home state, you are good to go. We are not going to check on anything, so be it. There are some states that are requiring that you register with the Board of Medicine and provide evidence of good standing in the state in which you are licensed. So, to the extent that you're a provider and you're looking to take advantage of state licensure waivers, it is really important to check to make sure that the state in which you are wanting to provide services and relying upon the state licensure waiver, that you've met whatever idiosyncratic requirements that state has. Next slide, please. So the next piece, and we talked about this in terms of Medicare, that in-office visits would be paid at the same rate as telemedicine and vice versa, and that was a really important piece in the context of Medicare. Well, even outside the context of Medicare, many states, and prior to COVID, didn't require private insurers to cover telemedicine visits, like at all. They just didn't have to cover them, sort of full stop. And then even to the extent that states had a law on the books requiring private insurers to cover telemedicine visits, many states didn't take that next step that Medicare recently took during the emergency to cover telemedicine visits at the same rate as in-office visits. And again, this really gets to a fundamental incentive problem for providers, and you can't fault providers for this. If you can't get paid for the work that you're doing, you're not going to do the work. And if you set up a scenario where providers are going to get paid more for in-office visits than telemedicine, the incentive is going to be to have in-office visits or to prioritize in-office visits. So, we've seen a shift here as well. So I just gave one example. In Massachusetts, Governor Baker issued an order requiring the state's group insurance commission, all commercial health insurers, Blue Cross and Blue Shield of Massachusetts, HMOs regulated by the Division of Insurance, to allow all in-network providers to deliver clinically appropriate, medically necessary covered services to members via telehealth and mandating reimbursement for such services. So again, you see states taking this step to do one of two things, either to require that telemedicine services be covered, and in the perfect world where you have full payment parity, which is what we call it, not only are private insurers required to pay for telehealth services, but they are required to pay for those services at the same rate as in-office visits. Next slide. So what do we think is going to stay and what do we think is going to go? This is like the million-dollar question, and Monica, I'm happy to hear what you have to say about this as well. Right now, and there's a lot of ink being spilt on this at the moment. There's a current debate about what provisions, particularly as applied to Medicare, will continue to exist. And there's some debate about the CARES Act and what aspects of the CARES Act will be made permanent. I think that, in advance of COVID, the arguments that we saw for having Medicare limitations in place for telemedicine really revolved around, number one, overutilization. That's always the worry that if you make access to healthcare services too easy, then people will be likely to overutilize those services. I think we'll see that argument resurface again here as these issues are debated. But the one thing that it's hard, once the sort of horse is out of the barn, it's hard to get the horse back in. And I think what we've seen is a really successful deployment of telemedicine. People who had previously thought, and this is just an attitude issue, that people who were reluctant to receive services via telemedicine, where providers were also reluctant to engage in telemedicine, thinking, well, can I really provide care via real-time audio visual or over the phone if I'm not sitting in front of a patient? And I think, those of us that are advocates of telehealth have often said, well, as long as the standard of care can be met without actually having to physically interact with the patient, sure, why can't you? Well, now people have been forced to do this, and I think it's gone over very, very well. We lacked data before now to actually provide some statistical evidence that telemedicine works when the standard of care can appropriately be met using telemedicine, and now we're going to have that data. So I think it's a question mark. Will CMS revert back and allow or force patients to be only services only to be reimbursed if you're in a healthcare provider shortage area or a rural census tract area? I don't know. Will in-home services continue to be available? I don't know that either. But my guess is that these are the more likely aspects of things to remain in place. I think the cost sharing requirement will go back in place. I think the HIPAA requirements, again, there's just a huge expectation of privacy, particularly surrounding healthcare. So my guess is at some point, OCR will reverse its position on HIPAA and will require telemedicine it would be furnished via HIPAA compliant platform. And that may create a barrier because it does cost some money to, subscribe to one of these HIPAA compliant services. So we'll see. And the state licensure, I think a lot of people really want the state licensure piece to stay in place so it's easier for if you're licensed in one state to provide services in any other state. I might be a little bit of a naysayer on that. We took a poll in our group and it seemed more people than not thought that these waivers would stay in place for licensure. I kind of fall on the no side. I think that states like to have an incredible amount of control about who's practicing medicine in their states. And so I think that we will see that probably revert. That's my own maybe too negative stance on all of it, but we'll see. And I think really the last really important piece is what's going to happen with payment parity, because that's always been a huge roadblock for telemedicine. And admittedly, I saw a quote the other day that CMS is unlikely to keep payment parity on the books, and that would be really disastrous as far as I'm concerned, because again, if you can't get paid and you can't get paid at the same rate for telemedicine as in-office services, then you're less likely to engage in those services. So that would be a shame, but we'll see. All of this is a little bit yet to be determined. I don't know, Monica, do you have thoughts you'd want to share on any of all of this mess?
Yeah, I think that's right and accurate. And I think one of the key deciding issues is going to be how long this continues. Because as the pandemic continues, people are concerned about second waves. We're seeing spikes in numbers. What I think that is allowing or will allow to happen is for the continued use of telemedicine and for the data that Kyle mentioned to be produced. So as we see, entire systems overnight going from, maybe providing, 5% of their care and services via telemedicine to going to 50% or more, including, in specialties and areas where we didn't previously see it. For example, in various surgical specialties, we're now seeing providers use telemedicine, visits for, follow-up visits, post-surgery, visits. And as, we gain, that use and that data, and as this goes on, I believe that there's going to be, my own personal belief is there's going to be enough data to show and to justify keeping the parity in terms of the payment parity and in terms of keeping the expanded access, allowing for the patients to continue to be in their home and have that qualify as an originating site, to allow for increased CMS coverage. I think it's going to be very difficult to unwind what's already out there. And as states are, seemingly, getting on board with this and also seeing the value, I believe that will continue. The one point I do in terms of the naysayer agree with you, Kyle, is on the licensure. I think states are, very protective of their own regulations regarding provider licensure, the individual state medical boards, the testing and all that goes on. I don't see that being relaxed, but I do see, my guess is that there'll be more states that will, for example, join the compact. Legislation will probably be produced to allow for some flexibility, but I also don't see the licensure exceptions being one that will likely stay in place. From a privacy standpoint, I agree that I think that the platforms are going to need to be HIPAA compliant, but what we're also seeing is a number of the technology providers looking ahead into the crystal ball and understanding that if they are going to have a viable product that providers and health systems continue to use, the technology manufacturers are, it's our understanding, working to develop and ensure that their platforms can be HIPAA compliant so that they would be able to continue to be used in a manner that allows for the services to be provided in a HIPAA and state privacy law compliant manner. So I think the longer this goes on, which is not necessarily good for the country, but it will potentially allow for the continued increased expansion and flexibility for the use of telemedicine.
Fair enough.
So with that, I'm looking, and I know there are, we've received a few questions here, and I'm happy to turn over. Hey Kyle, there was one question that I'll turf to you that is a question of do we know if there's any limitations currently or exceptions on the number of visits in relation to outpatient behavioral health in mental health services? I know that there have been some pushes, to the government to expand telemedicine, being used for outpatient behavioral health, such as being able to use just, telephone conversations, not have, the interactive, video. But do you want to speak on this?
I'm pretty sure that it's once every 3 days. I'm pretty sure that's what it is. Let me just see.
Yeah, that's my understanding as well. I think that, and I'm not aware of, and we can check and confirm for you, but I'm not aware of an exception to that was issued. So Kyle, I agree with that, but.
Okay. Yeah, I think that's right. I will look while we are talking. I know you can use audio only telephone evaluation for behavioral health counseling. That's been a thing that's in place. But
And other questions that is constantly going to been that we do see is in terms of the expanded applicability of the providers, such as speech pathologists, the clinical social workers, and that's another one that people go back and forth on whether or not the debate as to whether or not they will be continue to be included as eligible providers for telemedicine. I'm personally of the opinion that I think that so long as those providers are able to participate in Medicare bill for the services, I think that's one that will probably remain an exception so long as they again will meet. I think where that exception can remain, but the licensing requirements and any certification or registration requirements related to the profession and to the provider will probably also remain and still be governed at a state level. But that's another question that popped up. My own personal opinion is that expansion of eligible providers will probably remain as well.
add a link to the answer of the waivers in place that might provide Laura some background. It's hard for me to find it in real time, but I provided a link to the CMS waiver, so there may be the specific answer to your question, and that's a link to the CMS flexibilities put in place for COVID-19.
Great.
Is there anything else that we can
Answer?
Yeah.
Let's see.
The facility fee. I believe the answer to that is yes. Let me just see if I can find it. I know this was debated on a CMS call about the facility fee and whether or not the facility fee can be charged when the patient is at home. And this also came up in the context of whether the facility fee could be charged if you're utilizing telemedicine to treat a patient across the same facility. So there was a question about hospital in-hospital use of telemedicine, and can you get the facility fee? And I believe the answer to this was yes, but I would hate to be quoted on it. I'd want to actually pull the applicable waiver for that. And it may be that the facility fee was only applicable when using telemedicine on site. That could be the case. So I apologize for not having the answer off the top of my head to that, but I know it was something that was actively debated.
And I believe it was actually debated because it wasn't available in the traditional historical sense under it, where if the patient was at home, that wouldn't be billable, which is why I think it's something that was under debate.
That's right.
Great. Well, with that, I know we're at time. I want to thank everybody. I appreciate you giving us the opportunity to speak on this. And, you know, it's our hope and that, you know, the use of telemedicine and the coverage and reimbursement for same will continue to be embraced and increase.
Thank you, Monica and Kyle, for that excellent presentation. It was very comprehensive. With all the changes that are occurring at both the state and federal level in the legislators and the agencies, as well as the government or governor and presidential orders, it's more important than ever that this information is kind of distilled and passed down to the provider and administrator community. So we thank you very much for this very comprehensive presentation. I'd also like to thank everyone who's joined us for today. This has been the first of what will be a month-long webinar series that we here at PTU-HSC colloquially call Telehealth Thursdays. This coming Thursday, July 9th, will be Technology Trends During Challenging Times, and we'll feature the speakers Doris Barta, she's the director of the National Telehealth Technology Assessment Resource Center, and she'll be joined by Jordan Berg, who is a technology specialist at the National Telehealth Technology Assessment Center. So with that, we thank you all for your time, and we wish you a good rest of your day.
Thank you for having us. Thanks, everybody.
Thank you.